Well, kia ora tātou, everybody. Bruce Arroll's my name. I'm the director of the Goodfellow unit, and so I work at the university most of my time, but also a GP in Manurewa at Greenstone Clinic in South Auckland. It's my great pleasure tonight to welcome Dr. Gary McAuliffe, who's a clinical virologist who works mainly at ADHB and doing a little bit of work for the ministry over the COVID thing. He was formerly the clinical microbiologist at lab tests and Northland pathology. His interests are population health, molecular diagnosis of sexually transmitted and enteric infections. We won't be dealing with them much tonight. We're going to be dealing more with the upper respiratory things, but I think I'll invite him back for a common infections too. So we have 1,071 people signed up for tonight. That's getting close to our record of 1,400. So we're pretty pleased. So welcome everybody. We've got some new things, some new treatments on the block, so that will be pretty good. We're going to put in the there's a Q&A box at the bottom of your screen that you can put questions in. And you can ask general questions if you want about Gary, if you've got a general microbiological question you want to ask. Doesn't necessarily have to be on the topic we've got tonight. We've got a handout of about 14 pages, which is our common infections handout that we produce and keep up to date through the department. And this updates with the BPAC updates and anything that's new. We've got the new macrobid antibiotic for urinary tract infections added to that. And so we keep that up to date on a regular basis. So put your questions in the Q&A box, and we will be putting a link to that handout. That's in a PDF form now, and so that will be coming up in a little while. Okay, so this is called common infections, and there's the whole issue of antibiotic stewardship, which you would have heard about before. We know that about 50% of Kiwis get an antibiotic each year, and I think we'd all agree that's way, way too high. 95% of under 5-year-olds get an antibiotic by the time they're 5 in New Zealand. I have a colleague in the Netherlands, and they have about a 3% rate there, and he thinks that's too high. 3% is probably not unreasonable, I would imagine. Gary might have a view on that, but I think we'd all agree that 50% is too high. There's the issue of rising resistance, and you can use delayed antibiotics. I've done some research on that. Problem with delayed antibiotics is half the people go and pick them up anyway, and I think we should be learning to say no, come back for a reassessment. We need to offer reassessment, of course, in a fee-for-service environment. That's quite difficult. Pharmac had their big public campaign about 15 years ago and dropped the Moxil prescriptions from 1.4 million to 700,000, and it's sort of sat there since. Augmentin came down from 1.4 million to 700,000. There's the issue of C. difficile. That pseudomembranous colitis is the condition it causes, which, and probably the take-home message about that is if you want to check for C. difficile, you have to put a fresh, loose stool onto ice and take it to the laboratory and ask for the toxin. If you do a normal stool test, you won't get it. And in a former clinic, we had a problem with that. My colleague thought she was testing for C. diff, and she kept asking for stool samples. And the patient actually had C. diff, and it took about 3 or 4 months. We don't seem to have the deaths, and I might get Gary to make a comment on that at some point if you'd like to, that they do overseas, whether we're just missing them or it isn't as bad here. But in the UK, they have quite a few deaths. There's the issue of upsetting gut bacteria, and there is some thought that probiotics can reduce C. diff. So I might just say to Gary, any thought about the C. diff? Because my understanding in the UK, there are deaths. We don't seem to have them here.
So a lot of this was around hospitalised patients and high rates of C. difficile in hospitals with hospital-acquired disease. But we've never really had that. We've looked for it hard in our hospitals. We've had generally very low rates. I mean, I think a lot of it is about overcrowding.
Are they using more antibiotics in hospitals in the UK and overseas, do you think? Or
certainly over the last 10 years, the C. diff rates have come down in the UK because it's become almost a sensible event over there, and they've really made efforts, not just with antimicrobial stewardship, but also with not cohorting people. And
if you just speak up a bit, Gary, you're just going a bit quiet there, sir.
Yeah. So I mean, I think it's a combination of things, including antibiotic stewardship over the last 10 years that have brought rates down in the UK, and changes in the construction of hospitals and how people are to try and reduce the risk that you're going to acquire it there.
Yes, and certainly having been recently admitted to a hospital is a risk factor. So I think it's the biggest risk factor, I think, isn't it? Recent admission to a hospital. Yep. Okay, so there's a primary care antibiotics are usually discretionary rather than mandatory. There are a few mandatory things, and there's been a move in recent times to shorter courses with perhaps slightly higher doses. So this thing of finishing your course of antibiotics, well, given that most antibiotics aren't given for bacterial infections, they're given for viral infections, finishing the course is really just giving antibiotics to normal bacteria. So there are some conditions where antibiotics are mandatory: strep pharyngitis, perhaps certainly in Maori and Pacific children, some cases of otitis media, and cleaning pneumonia. And one thing I always like to remind people of is patients with severe symptoms, and we probably do err on the side of caution there, because if you look at the otitis media trials, they remove people with severe illness. So they often are studies in primary care of people who aren't very, very severe. And remember, most antibiotics are given for symptoms, not bacterial diagnoses. And there are some conditions like cellulitis you can't get an antibiotic, or you can't get a diagnosis for unless someone gets septicemia, and we don't really want people to get to that point, unless we can find the portal of entry, but that's sometimes difficult. So we're just going to talk about urinary tract infections. And in general, I think we would only do midstream urines if patient had previous infections, because we're interested in resistance organisms. Gary might like to advise us on that. And I think this is the first new thing we've got tonight, and that's nitrofurantoin is now in a twice daily form, but the only way to get it is to write macrobid. You have to write the trade name into your computer, otherwise you'll just get the old dose of 100 milligrams BD, which may not be enough, and trimethoprim is now second line. So, and that is for 5 to 7 days, basically. So we've got a case here. A 22-year-old woman in a new relationship presents with dysuria and frequency, first event. Vitals are okay, no flank pain. Do we need to do an MSU? I don't think a dipstick would change our management in this case. We'd be looking for leukocytes, but I think with dysuria and frequency, we would probably give an antibiotic. And I think in this case, we'd give macrobid for 5 days and anticipate any adverse effects such as diarrhea or nausea. Nausea is a problem I find with nitrofurantoin, and vaginal thrush. So that's always something to think about. Gary, any thoughts about that at all? The value of a dipstick?
I don't know that a dipstick would be particularly valuable. Obviously, in this case, you're wanting to know if she's got vaginal discharge and whether she might have an STI as well. The other thing to mention is just around the change to trimethoprim as second line. So that's some work that I think you were involved with, Bruce, in the last couple of years through the community laboratories in Auckland, Nelson, and Dunedin, where we saw that the rate of trimethoprim resistance in uncomplicated UTI in women was about 26-27%, which was far higher than we would want for empiric treatment.
Yeah, well, that's 1 in 4 not going to get better, isn't it? So that's so it's a pity. So you're looking at twice a day. The issue is, and we got into a bit of flack over the gem we put out on this about what EGFR. I think there's international consensus that an EGFR of 45 is and above is okay. And I think you'd say, Gary, if it's resistant to everything else, well, you might want to try it, irrespective of the EGFR.
Absolutely, down to about, I think we've got a slide on this, down to a GFR of 13. If you've got a
speak up a bit, Gary.
Down to an EGFR of 30 if you've got a multi-drug resistant organism and you've got no other choice.
Okay, so just getting someone's getting heaps of echo, not sure why. Is there a role for preventative with high dose oral antibiotics for adults? What about STI screening?
We'll talk about an example of this shortly.
Sorry? You're coming back to that, okay. Will you do a swab for chlamydia? Would you say yes in this case? Gary, would you suggest a swab for chlamydia in this woman's case?
Not necessarily. I think we would just treat her empirically for a UTI if she doesn't have any other symptoms.
Okay. So I've got a question here. UTI case, if dip was clear, wouldn't you look for other causes? Why give antibiotics for a clear dip? I just remember a study that Dee Mangan did, and she found with people with dysuria and frequency, they still responded to antibiotics even if they grew nothing on the urine. The suggestion being there's some bacteria we can't grow, but antibiotics get rid of. I don't know where you stand on that, Gary.
I think there's a role for dipstick if you've got it available, but equally in this situation, I think going ahead and treating would be fine.
You'd hope the dipstick would be positive in this case.
Yeah.
Okay, so that's the questions. Got a few more there. With trimesopran, second line for UTI, do you see remaining available via pharmacists? I guess that's going to be a risk, isn't it? It might disappear.
Yeah, so this was something that the pharmacists were keen on discussing when we presented the findings of the study, because that's really the only option that they've got over the counter at the moment. But I think time will probably tell. There may still be a role for it as an alternative way of getting treatment, but obviously if people have still got ongoing symptoms, they need to seek primary care anyway.
Would you do an MSU in this case, first UTI?
No.
Okay. So unclotted UTI has assumed a course length of 3 days as per BPAC. I don't think that's true for nitrofurantoin. I think it's always been at least 5 days. I would have to go back and check that. Is trimethoprim still being dispensed directly by pharmacists? I suspect it probably is. Placebo effect. Alan may have to just elaborate on that. I'm not sure. Okay. So let's just keep going. Okay, so we've talked about that. Seems to be very little resistance to nitrofurantoin at the moment, Gary.
Yeah, it tends to be more of a problem with repeat offenders and people who have recurrent urinary.
Sorry, just speak up a bit there, Gary.
It's more resistance for nitrofurantoin is more of a problem when someone's had recurrent infections and have been treated with it in the past. But yeah, generally the rates are low of resistance.
Okay. 32-year-old woman presents with dysuria and frequency, 5 UTIs before on oral contraceptive, vitals okay, no flank pain. Would we do an MSU here? Gary, would you suggest an MSU after 5 UTIs?
Depends what our last ones were.
Yeah, I guess that's true. Yeah. And then there's this whole issue of antibiotics and oral contraceptives. I know there's new advice saying it's not a problem, but having worked with a woman about 20 years ago who got pregnant taking antibiotics on oral contraceptives, that one of my colleagues has pointed out today, sometimes it may be the diarrhea stopping the absorption of the oral contraceptives. I don't know, I don't know if you want to make a comment on that, Gary. I always suggest women be cautious if they're on oral contraceptives.
Yes, it's not a question I've been asked, so I can't give you a...
Sorry?
It's not a question I've been asked, so I can't give you a comment.
Well, it's another reason for continuous use of oral contraceptives, because you reduce the risk of ovulation, much more so with no periods, and you reduce ovulation. So I think many young women now are taking regular active pills. Okay. So Gary, your case.
Yeah, so this...
Just tell me when you want to change the slides.
Thank you. Yeah, so this is a sort of case that I get asked about in the community. An 8-year-old woman with frequency in dysuria, and her eGFR is 45 mils. Her urine, she's got a Klebsiella pneumoniae, which is very resistant to our first line drugs, including trimethoprim and ciprofloxacin and augmentin. And some of the options we've got are nitrofurantoin, fosfomycin, mesalamine, amikacin intravenous. So we've already talked about, if we just flick forward, we've already talked on that slide. We've already talked about the use of nitrofurantoin in this situation. So she's got an eGFR that's even down to 30. I would happily use nitrofurantoin as the first line if she has no contraindications. And then if we move forward onto the next slide, the other two options, if that was not available to us or her, are fosfomycin, which we use with increasing frequency, unfortunately, in the community, which is, as many of you will be aware, given as an oral sachet of 3 grams. Often I just give it once on day 1, but if someone's got ongoing symptoms, we'll give them a further dose on day 4. But that's useful for E. coli and enterococcus, but not for Klebsiella pneumoniae generally. Mesalamine is another drug that we have now got available through POAC in the Auckland region that can be given for 3 days, but may need renal impairment dosage adjustment.
Okay, thank you. So cellulitis, so skin infection, strep or staph. We always need to check the vital signs in these patients. There is a new way, and it's in the guidelines. You can now give flucloxacin 3 times a day with food. You have to give 1,000 milligrams rather than 500 out for 5 to 7 days. The theory being with the 5 days is if the vital signs are okay, most of the bacteria will be killed and you've actually got inflammation rather than infection there. So that's something to think about. And then there's the option of kefazolin 2 grams with 1 gram of probenecid. Ironically, the probenecid become the expensive part of the equation and difficult to get. I can remember the days when probenecid was next to nothing. We used to give amoxil and probenecid for gonorrhea. And now in those days, the probenecid was cheap and the amoxil was expensive. But I know there is some work on, they're suggesting now that actually oral antibiotics are probably as good as those IV pushes, Gary. Do you have any view on that at all? Just try and speak up if you can. Though.
Yeah, so generally, unless somebody's particularly unwell, trying oral first is very reasonable. I think my comment here would be often things look worse before they get better. So it may be not until day 2 to 3 of treatment that you start to see an improvement, and you may get an initial increase of redness before the antibiotics kick in.
Yeah. And of course, if you give 10 days for everybody, you're never going to know if 5 days works. So, and it's interesting, I remember a colleague of mine saying, we make up the duration of antibiotics in primary care. And I had to laugh, because when I go to audiences, I say, who gives 3 days, who gives 5 days, who gives 7 days, who gives 10 days? And different hands go up for different durations. So there's some truth in that. Uneven numbers till 10, and after that, it's even numbers. That's about the only rule. Okay, so this is cellulitis, and no obvious portal of entry in that. This was a chap I saw some years ago. He had recurrent episodes of cellulitis in his leg, and finally the hospital checked between his toes and found that he had quite extensive athlete's foot, and treated his athlete's foot, which fixed things. So I think it's worth checking out portals of entry. They may or may not be a cause, but presumably that maybe happens more often than we think. Okay, and I guess you may agree with this. My feeling is you're going to give oral antifungals, you'll need to have a microbiological scraping at least before giving them the risk with terbinafine is about 1 in 500 taste loss, and I've actually had 2 patients with it. It is temporary. If they stop it, the company says most people will recover from it. I haven't seen any permanent taste loss, but it does make me a bit twitchy. Sorry, Gary?
Oh yeah, I lost my taste. It wasn't pleasant. But it did come back.
Well, it's hard to know when it comes back, isn't it?
Yeah.
It happened to one of my relatives, and she's a foodie, and she was beside herself, really. Yeah, so well, that's 3 now, Gary. I now know 3 people. You've doubled my thing. Okay, so the common cold. Antibiotics, no use. I was part of the Cochrane review. And I think it's fair to say the secondary bacterial infection is really a myth. I think we all cough up coloured sputum when we have a respiratory thing. There may be a little low-level bacterial thing, but not warranting antibiotics. Unfortunately, now we can't use pseudoephedrine, which was the most amazing decongestant. It just isn't available here anymore. And I don't think it was used in the methamphetamine chain. Methamphetamine's coming in 500 kilogram lots amongst car parts at the moment, or in tablets. The ones you give your local accountant aren't going to end up as methamphetamine. So the nasal decongestants are an option. The Sinex ones, there's xylometazoline. The problem is they're about $15, and they do cause blood noses after a while. There is iprapropium nasal spray, which is fully funded, and then just simple old non-steroidals and paracetamol for body aches. Vicks works in children. People still talk to me about putting it on kids' feet. I suspect it just wafts up, but the study they did, they put it around the mouth and around the cheek. The other thing I do with common colds is say to patients, the cough may last for three to 4 weeks. Otherwise, people are back in a couple of days saying, my cough hasn't gone away, give me antibiotics. So I think reminding people that it does take up to 4 weeks for a cold to go away, for a cough to go away. Clearly, if the cough keeps going, then you might want to try an antibiotic, maybe a chest x-ray at some point, depending on the age. Gary, do you have a view about the secondary bacterial infection myth? Because it's a big reason cited for giving antibiotics in primary care.
Yeah, I think it is a myth, and you'll be aware that you have a lot of pressure on yourself, not only from the patients, but also your anxieties around what might happen. But overcoming those is very valuable.
There's a question here about interstitial cystitis, recurrent urinary tract symptoms with a clear dipstick. I guess that would be a situation where a normal dipstick would be quite useful. Somebody saying if Gary turns towards the wall, we can hear him better.
To the wall.
So I don't know which wall, maybe the, okay, so here we've got a thing, patients are advised not to use urine sachets as can interfere with nitrofurantoin. So not sure. Okay. Unable to read slides, not sure. Okay. With ESBL, often only antibiotic that works. So why is it first line? Please, could that be corrected? Not sure. Anita, if you could just expand on that. Lucy and Cronin, nitrofurantoin with food? I don't think it matters, actually. Can we talk or bust the need for antibiotics for green snotty nose? I think certainly in the acute, if you've got a snotty nose going for a month, then perhaps antibiotics is worth doing. If you've got a child with pus coming out of their nose, it's not much fun. Do I have to stay off work for 3 to 4 weeks for my cough to go away? My COVID test was negative. Advice is to stay home until symptoms are gone. This is a very important question for all of us. Do you want to answer that, Gary?
Well, the answer is no. You can't stay away for that long, and you've had so it becomes a risk analysis, doesn't it? What is it about your acute illness that you've still got? You've not got a sneezing. You've not got a productive cough. You've not got a fever. Otherwise, there's no way that you're going to have to stay off work for 3 weeks.
A bit more information how Vicks works, please, with feet. I don't know. I suspect it just radiates up off the feet. Okay. Sudamol still available controlled drug. I don't think that's correct, actually. Any tips for finding the Haemophilus influenzae amongst the viral UTIs? How to tell bacterial H flu infections if you don't have a sticky ida culture in this particular family? Don't know if you've got an answer to that, Gary.
So if the question's about telling Haemophilus influenzae from viruses, I mean, the presentations that you've got here are all viruses, as in it's unlikely that someone's going to acutely present with a bacterial nose infection or a sinus infection.
Just come forward a bit there, Gary.
Yeah. So it's unlikely that somebody is going to present with an acute bacterial nose or sinus infection. And it's most likely that it's going to resolve of its own accord within the next week or so.
Okay. Can you repeat the use of Vicks for kids around the nose? And I think it was on the chest. I actually tell people to put it around the nose because then it's wafting up into the night. Flu clocks are still in with food. Thought it'd be on an empty stomach. That's the change. I announced that at Red Whale a couple of years ago, and the audience cheered. They were so, because getting flu clocks into somebody on an empty stomach is not a lot of fun. And with children, we actually do suggest for taste Kefalex, and it's very hard to get flu clocks into children. Although with food, it might be easier. Okay. Don't know about the interaction between urine and nitrofurantoin. I think you'll have to look that up on your adverse effects thing. Saline nasal washes work well for colds. That's something to think about. Okay. Does buckling work to prevent bacterial complications of the common cold? I don't think so. I think that's a con, isn't it? Yep. The rest easier, Oliver. Just tell people to keep their money in their pockets. So one doctor here says, I find it difficult to convince some patients not to have antibiotics. So I think that's a situation you might want to try a delayed prescription to say, see how you go without something. And if you're not getting better, in the UK, they say come back after a week. I think that's a bit more difficult here when people are paying money. But the problem is if you give antibiotics to everybody, we know from the research they're more likely to come back the next time. You completely medicalize people. and you'll have them knocking on your door forever. We took over the practice of a doctor who gave antibiotics to everybody, and those patients, this is like 10 years later, are still coming in wanting antibiotics for every little cough and sniffle. So you create a monster. There's a good thing there from Waitamatar guidelines, I think. Why we don't use Arroll anymore. I think maybe it doesn't seem to be used as much. There's Hiprex for repetitive UTI. As far as I know, that's effective. I don't know if you know much about that. It's an unfunded prevention drug. Do you know anything on that, Gary?
We have a small group of women who get to that stage, usually in conjunction with a urologist or a gynecologist, and they get to the stage of trying anything, including Urinary. So I'm not entirely sure how well it works, but I know that it's used because there's no other option often.
Is there a place for oral zinc in acute viral UTI? There are a few trials which show it does seem to work. I think one of the issues there, in a population that's got plenty of zinc in its diet, would it still work? So there are a couple of trials, but the problem with a lot of these issues, there just hasn't been enough things. Okay. I mean, for the last one, I still believe it's available. Okay. Mark, I think pseudoephedrine is no longer available. I've asked the pharmacy, but maybe Vivian from up north can answer that. She will know that. Hiprex is now funded, isn't it? I'm not sure. Maybe somebody can update it. Yep, somebody says Hiprex is funded. Cool. Great. Yeah, no, the evidence is that it does work. There are a few trials. Okay, got lots of questions there. Sorry, missed that. Is ipratropium fine? Yes, the nasal version does reduce acute rhinitis. It doesn't affect congestion, but the runny nose it is quite effective for. Yep. Right. So we're still not 100%. If you ever tasted oral flu clocks, you'd never chart it for children with or without food. Yeah, no, I can sympathise with that. Okay, well, let's keep chugging on. So on to sinusitis now, and it's quite interesting. On the health pathways, they talk about what's clearly a viral one, and there's a cluster of symptoms: facial pain, nasal discharge, dental pain, and nasal congestion. Now, most of these in our community are viral, but people do occasionally get very sick. I've never seen anybody very sick with sinusitis, but I guess you probably did in your training, Gary, the odd person with an abscess in the sinus. Right. It's more ENT territory, is it? So, well, if Gary, yeah. So I think here we give nasal decongestants, analgesics, nice guidelines, suggest intranasal steroids, maybe try rinsing. I don't know what the evidence is around that. But it's a source of antibiotic use. 80% of people in America get an antibiotic. The guidelines then go on to say acute bacterial rhinosinusitis with purulent secretion in the nose, fever greater than 38 degrees, severe local pain, predominantly unilateral, deterioration after an early improvement in initial milder tenderness. Now, I've tried to check down that's the so-called second sickening, and I've tried to track down the origin of that. As far as I can find, there's no empirical evidence. I think we all think this makes sense. You get a cold, you get better, you get bacteria, they cause bacterial sinusitis. That sort of makes sense, but there's no empirical evidence around that. But it appears in a lot of guidelines, the second sickening. I think if you had somebody with a fever of 38 degrees, you might want to give an antibiotic. I don't know what you think, Gary, but most of these people, I don't think I've ever seen anybody with that cluster of symptoms. Maybe once. Do you have a view, Gary?
Mainly that I wouldn't go on a fever of 38 degrees. I think you're looking for some, getting worse. Rather than,
yeah. Okay. So I think, if we could reduce the antibiotics for this condition, we would do a lot. The so-called second sickening. I think if you have got somebody who's getting worse and very febrile, you may want to discuss it with an ENT registrar or consultant. Duration of antibiotics. There have been some studies of 3 days. I think 10 days is overkill. I don't know if you have a view, Gary, on that. If you're going to give antibiotics.
No, I definitely think 10 days is too long.
Is what?
10 days is too long.
Too long, yep. Okay. Rightio. So patient presents with a 2-day history of sore throat, rhinitis, cough, pressure over maxillary sinus. Last doctor gave augmentin 500 milligrams TDS for 10 days. Vital signs normal. Does not look sick. Any examination, there is the, when you put the powerful light in people's mouth, I don't know how useful that is as a clinical sign. The American textbooks all mentioned. Okay. I've forgotten the term. Maybe someone can remind me of the term. When you stick a light in somebody's mouth and see whether the sinuses. I have to say, I don't think, because you can put the speculum lights into people's mouths as a powerful source of light. Transillumination. I don't think it's, I really can't tell. I've just never been particularly helpful. But I think with that picture, you would just treat that as a cold with sinus symptoms, basically. Would you say so, Gary?
Yep.
Yep, okay. How do you check if the patient wants antibiotics? Well, one of the ways I say to somebody, is this, I use the passive voice, is there something you're hoping specifically we can do for you today? And that usually gets out the antibiotic question rather than, I hope you're not expecting antibiotics today. That requires a little bit of clinical skill. Ruling out bacterial sinusitis. I don't know, is there any place for doing CRPs, Gary? No, don't complicate it. Okay. Righty-ho. So how are we doing here? We're doing pretty well. Okay. So treatment for rhinitis is ipratropium. It's funded. For congestion or rhinitis is xylometazoline. For cough in children, honey or Vicks. Honey for kids over 1. There is the issue, I think, of listeriosis in younger children. I think the over-the-counter cough mixtures, the evidence around those is very shaky, and they're quite expensive. And as I say, it may take a month to remove. So it begs the question: should we ever be giving antibiotics in the first instance? And I think, as Gary sort of said, if people are getting worse rather than better over a period of days, that might be a situation for people to get an antibiotic. So over to you, Gary. We've got 1, 2, and 3 here.
Yeah, this is a question for the audience. Which one is group A streptococcus? Is it number 1, number 2, or number 3?
Is there just one there with group A streptococcus?
Yes.
Okay, so into the Q&A box, put your answers, folks. We'll see. Is 1, 2, or 3 got the transillumination? Thanks, Tom. One, 3, 1, 1, 1, 1. Could be all of them. 3, 2, 1, 1, 1, 1, 2, 1, 1, 1. Okay, thank you, team. 2,
Thanks.
2. Okay, put us out of our misery, Gary.
Yeah, it's not 2. Number 2 is probably Coxsackie or some other enterovirus. It's unlikely to be HSV based on the rest of the math. It could be number 1 or number 3. I've forgotten which one it is. But the point here is that they look the same as EBV, group A strep. Generally, it's making a differential diagnosis between the two is incredibly difficult. Can we have the next slide?
Okay.
So this slide really summarizes our New Zealand approach to treatment of group A strep sore throats, which is because there are a group of people who are at high risk of rheumatic fever, and there are a group of people who are at very low risk of rheumatic fever. So Maori and Pacific people are at high risk of rheumatic fever, and the risk is highest in Pacific people, whereas the risk for a European child is less than 1 in 10,000 after an episode of group A strep pharyngitis. And really that pushes it down into the territory whereby treatment with antibiotics is more risky. And from my perspective, this is something over the last few years we're trying to increase the knowledge of in order to try and reduce treatment for group A strep pharyngitis, unless somebody's epidemiologically at risk for rheumatic fever. Certainly in Europe, I know that treatment has plummeted, and it's generally not considered that group A strep pharyngitis needs to be treated. The main exception, obviously, is that we've got a population, on the other hand, who are at very high risk of rheumatic fever. On the left there, I'm not expecting you to see that. That's just the illustration of the Heart Foundation guidelines around sore throat swabbing. And
so Gary, on figure 3, you've got a reduction in rheumatic fever. Do you think, is that thought to be due to the school swabbing?
Initially, if we'd seen this graph back in 2015-16, it was very hopeful that that was the case. However, 2016 was the end of pretty much the end of the school-based sore throat swabbing, and we saw an increase, particularly in Pacific people in the following years. So it's actually probably thought more to be chance and seasonality rather than actual improvement to school sore throat program. So
would you think then that the school swabbing may have made a difference?
No.
No. And the other thing to remember is that the treatment for strep throat is now amoxil once a day with or without food for 10 days. You've got to do the whole 10 days. Well, I think penicillin twice a day, isn't it? You can use penicillin.
Primarily, it's been amoxicillin used in the
primarily amoxicillin.
Right.
So yeah. Okay. Next slide for you, Gary.
And this is a case of somebody that we would treat, and just a word around antibiotics. So a 7-year-old Maori boy, his second sore throat in 2 months. We've got group A strep isolated from his throat. He's allergic to penicillin, cephalosporins, and he can't take erythromycin or roxithromycin. So what would we give him? And
next slide.
Yep. The question here is, what about cotrimoxazole? So we've never given cotrimoxazole for rheumatic fever in the past because we always thought group A strep was resistant.
Just losing you a bit there, Gary.
We've never given cotrimoxazole for group A strep infections historically because we thought it was resistant. However, we now know that that was because we were doing it wrong in the lab. So we've started using it for skin infections over the last 5 years or so, but the problem with sore throats is that we don't know that it doesn't prevent rheumatic fever. So no, we can't use that in somebody who's at risk of rheumatic fever.
So just repeat the last comment there, Gary.
We don't know that it doesn't prevent rheumatic fever, so we can't use it for this boy.
Right.
So we could use clindamycin.
Because the rheumatic fever story is interesting, isn't it? I mean, the only studies which showed reduction in rheumatic fever have been the injectable ones back from the US Army in the 1950s. So, okay.
And this, we've covered some of this already, but these are some of the reasons why
Losing you there, Gary.
These are some of the reasons why, when talking to your patients, you can explain to them that not everybody needs treatment for group A strep in throats. Most group A strep infections are self-limiting. Antibiotics reduce the symptoms by a day. And in fact, most sore throats, even if you grow group A strep, are viral, because 10% of kids are colonized with group A strep in the winter. Complications, we've talked about rheumatic fever, but quinsy and other complications are very rare outside at-risk populations, and giving amoxicillin or penicillin out for this is potentially promoting antimicrobial resistance. So a sore throat doesn't necessarily need a swab in a MARI non-Pacific child, and it doesn't necessarily need antibiotics. Symptomatic treatment may be all that's needed.
Just going to make a comment about, you mentioned quinsy there. I've only seen one case in my life, and it was a Maori man aged 20, and I couldn't get his mouth open. And I had a registrar when I phoned up and said, I think the guy's got quinsy. He said, I don't think you've examined him properly. I said, I find that insulting. Who's your consultant? And he saw the patient and he couldn't get the mouth open either. So that's trismus. So that's when the muscles of the jaw are, so if you can't get somebody's mouth open, even though they want to, then you're probably dealing with a quinsy and you want to hospitalize them. But this guy hadn't eaten or smoked for 3 days and had a fever. So, I mean, that on its own, you probably want to admit somebody, you know, that's a very serious history. Okay, so otitis media. So a high-risk patient is somebody with systemic symptoms, or it's recommended we treat them less than 6 months in all cases. This is on the BPAC guidelines, less than 2 years with severe or bilateral infection, with perforation or otorrhea, or no improvement within 48 hours. Perhaps children with recurrent infections. Otherwise, treat symptomatically, paracetamol, back pocket script. So that's otitis media. The interesting thing about this is it's slowly disappearing in our community. I used to be able to show a medical student in the 4 weeks they were with us an otitis media. That's becoming hard now, and they think it's due to the H flu vaccine, and the pneumococcal vaccine is making this go away. So it'd be interesting to know if others have noticed a decrease in that. So again, amoxicillin is the antibiotic, 15 milligrams per kilogram per dose. So that's 45 milligrams a day, up to 30 milligrams per kilogram per dose in severe or recurrent infection for 5 days. They're suggesting here for 7 to 10 days if under 2 years, or bilateral or perforated drum. And again, I tend to treat, it's much more common in Maori and Pacific children, and I'm much more likely to treat them with antibiotics, I think, because of the risk of mastoiditis. But I often say to people, if they've got unilateral otitis media and the child isn't too distressed, I'll often say, we don't routinely give antibiotics for this to the parents. What are your views on that? And I have to say, I find parents often, if I put it to them that way, they're not that keen for their children to have antibiotics. So I think the selling or not selling of antibiotics requires a little bit of narrative nuance. Don't know if you've got a view on that, Gary.
No, we tend in the hospital, we tend to be harsher, and I think that's
just come forward a bit.
In hospitals, I think we tend to be a bit harsher with people coming into pediatric clinics. but I think that you need to develop an ongoing relationship with them, and that sounds like an appropriate way of doing it.
Yeah, just got a few questions there. Somebody's seen 3 thoughts on using prednisone for sore throat for its anti-inflammatory effect. There is evidence that a stat dose of prednisone for somebody with a severe throat can help with symptoms. You want to be pretty sure. And it's been done in people with possible strep throats and not. Just remember my gem of 2017, short courses of steroids are associated with fracture, numbers near to harm of 800, DVT and septicemia or infection, NN harm of about 2000. And I broke my ankle on the death zone of Mount Eden when I was on 40 milligrams of prednisone. So I think you have to be very careful, even with short courses of prednisone. Okay, Quincy at age 25 after 1 week of antibiotics. Okay. You're definitely rare. Alan Moffat saying definitely rare to see good going otitis media. Yep, the old guys are all soft antibiotic eardrops. We're coming on to that actually. Dexamethasone for sore throat. I think dexamethasone has been the steroid studied in. Any comment on the percentage of bilateral otitis media that will be viral? Do you know anything about that, Gary?
Pretty much all of them. And the other comment I think that illustrates what you're saying about not seeing as many eardrums like your picture is most of them are difficult to tell whether there's something there. And I think there's a study in the US, it might have been on Up to Date, that says half the time doctors get it wrong.
Yeah. Yeah, I thought the evidence of a stat dose of dexamethasone. I don't know whether it's 8 milligrams, but I don't even know that's in the pathways. So, okay, so we're right there. Okay. This was a trial done in the New England Journal of Medicine, a trial that surprised me. Augmentin for 5 versus 10 days. There was, remember that antibiotics only help with symptoms. They don't speed up resolution. So there was an 80% resolution of symptoms with 5 days and 90% with 10 days. But in the 10-day one, 30% of the kids got diarrhea. There are very few symptoms, adverse effects in the first 5 days. In the second 5 days, 30% got diarrhea and nappy rash. And I don't think your parents would be thanking you very much for the nappy rash and diarrhea. I don't think there's, Augmentin is sometimes used for failure of amoxil, but I have to say, I don't think I've ever, I mean, if you look in an ear, it's not going to be 100% 5 days later anyway, but I've never seen anybody who's gone on with so-called resistant otitis media. And I suspect it's marketing from the pharmaceutical company who brought out Augmentin. What do you think, Gary?
I think there's a small group of particularly Maori and Pacific children who've had recurrent otitis media, and they do develop bugs in their ears that are resistant and require treatment, but it's a handful.
That'd be a case where you give Augmentin if they were. So how would you determine that? Would they still have symptoms, uncomfortable?
Yeah, or ongoing pus after amoxicillin would probably be those. And they're likely to have complex care needs and probably be under pediatric follow-up.
Yeah, okay. Okay, so this is a 15-month-old Maori boy presents with fever and bilateral otitis, medium bulging drums. What antibiotic would you give, dose and duration? Probably I'd go back to Denny Lennon's days of 90 milligrams per kilogram per day. Just saying that antibiotics improve symptoms, but not outcomes. You don't get more or less glue ear if you give antibiotics. So we're really giving it for pain relief at day 2, day 3. Any view on that, Gary?
No, I think the only thing to say is I've never treated someone on the basis of whether they are Maori for ears, but I can see your reasons around that, as in that would still potentially offer a back pocket script, because the majority are going to resolve within 16 to 24 hours.
Okay. Okay. So this is the Pākehā boy presents with unilateral otitis media, bulging drum and grumpy. I have a question here. In pediatrics, we're always told to examine the heart first, but I think in primary care, the heart is rarely a cause of concern. It's the ears you want to look at. And I like to look in the ears while kids are quiet. And in this case, I would say to the parents, we don't necessarily give antibiotics. You might like to give a delayed prescription. Interestingly, in the delayed prescription study from Southampton with Paul Little, only 25% of patients picked up the prescription. And there's some evidence that adults like antibiotics themselves, but are less keen on antibiotics for their children. A little bit of qualitative research around that, which is interesting. Okay, so that's my little, we don't routinely give antibiotics for this condition now. What do you think? And perhaps give a back pocket. Okay, ear canal pus. Now you think we would have all the answers to this, but it's still the last trial on chronic suppurative otitis media was 30 years ago. In fact, I've just challenged the ORL department at the university to try and sort this thing out, because I think New Zealand's a place we could actually do a study, because we still have a reasonable amount of this. So the issue is whether you should give antibiotics and steroids, or whether antibiotics alone or steroids alone. Certainly steroids alone probably aren't effective for chronic suppurative otitis media. And earlier on in my practice, I used to see a lot of elderly Maori with poor hearing and pus coming out of their ears. I think that group have almost died out now. I haven't seen that for a long time. Be interested to know what the audience, whether you've seen any elderly Maori patient with, because the thing on the, with Pat Isdale Moore on the East Coast, down in the Ngāti Porou country, the kids would have runny noses, which of course isn't a problem, and they'd have runny ears. And before he used to go down there, people used to think that was normal. But obviously some of these people have gone into adulthood with perforations in their ear. Those perforations need to be closed by about 8 years of age. So the ENT people like to close them there. So that's pus coming out of the ear. The issue is of swabbing. I don't usually swab. I just talk to a nurse in Whakatane, and they swab and they find a lot of aspergillosis, which be a good question for you, Gary. Antibiotics are generally not indicated. And I have to say, I used to work in Northern Canada, and we'd have 10 kids in our little hospital at any one time with pus coming out of their ears. And they pretty well all got better with drops in their ears. We didn't give them antibiotics, and we didn't use suction on them either. So I tend to think of pus coming out of the ears. In children, it's likely to be chronic suppurative otitis media. In adults, it's likely to be otitis externa. The only advantage of suction is you can see if there's a perforation. Like in an adult, you can see if it is coming from the eardrum or from the external ear. And I think if we were funded for Cipro with hydrocortisone, we would probably use that. But the Cochrane review is sort of cannot say whether you can just give antibiotics alone. So Gary, do you want to chip in here?
Yeah, so my comments here around swabbing is we wouldn't recommend swabbing unless somebody had had a couple of weeks of topical treatment and it hadn't worked, or if they had had recurrent disease. The topical antibiotics generally, looking at their health pathways, they're indicated for pretty much everything that's coming out of your ear. And
shall I say that again, Gary?
yeah, so topical rather than oral antibiotics are indicated.
Topical rather than oral.
Yeah.
Yeah.
And ciprofloxacin, I agree. I think that there's some studies that show superiority, but in general, your Locortin, your Vozol, your Sofradex will all work.
You can use Cipro funded for the eye, but you have to explain to the patient. I literally had a patient who put it in their eye following the instructions on the box, in spite of the fact the pus was coming from their ears. So you really have to say, look, we're bending the rules here a little bit. This is a way of getting funded ciprofloxacin. Volsol apparently is not available anymore, and I don't know if acetic acid is. This nurse from Whakatane or the pharmacist I spoke to said a bicarbonate or iodine is an option. Locortin has got a steroid, and chloroquinol, because I challenged BPAC on this, they said it does have some antibacterial properties. It's also available in Betnavate C. It's still available. I don't know. It's supposedly antifungal, but the one that is funded is Kenicum. But you're getting 2 antibiotics and nystatin, which is all a bit too much, I think. You don't need the nystatin. Sofradex, there's a part charge. You can get Framacetin, there's a part charge. Ciprofloxacin eye drops, if you want to bend the rules. For topical steroids alone, no evidence. And just remember, there is a condition called necrotizing fasciitis. And I don't know if you've ever seen a case, Gary. You may have. I've never seen one. But this is probably an adult with diabetes and severe pain. They need urgent referral. That's a serious condition that needs debridement. You seen a case, Gary?
Not from the ear, but yeah, elsewhere.
You know about them. So what was that, Gary? Just speak up a bit.
Oh, not around the ear, but yeah, on
other parts of the body.
Parts of the body.
My understanding is it's pain greater than you would expect for the for what you're looking at, like if it's on the leg or somewhere.
Yeah.
Yeah. So you can also get cholesteatoma. So necrotizing otitis externa is in somebody who's got problems with their immune status. I just got a case here. 16-month-old presents with pus coming from both ears, afebrile. So Gary would say no swab needed. Some of the trials have suction, most don't. Oral antibiotics generally not needed. For topical, the easiest one is Kenicum. And in the child, the pus is probably coming from the middle ear. My view in adults is otitis externa is due to cotton bud use, and almost everybody who's got otitis externa uses cotton buds. So I use the old saying, don't put anything in your ear smaller than your elbow. But it is rather nice to put a cotton bud in your ear and scratch around, but I don't think it's good for your ear. So swab not needed, suction not necessarily, oral antibiotics no. So that's just saying what I've said there. So this is very interesting. This was a man, a 55-year-old man, very fit. He had a cochlear implant on his right side, and he had painless pus pouring out of his ear. Now, this is completely out of my experience. I've known this guy for a long while. I did a swab on him, and I'm very glad I did, because this guy actually turned out to have mastoiditis. And so when he was admitted to Auckland Hospital, they had sensitivities, because he came back a couple of days later and his face had started to swell. And I presume the mastoiditis is a function of when they put the cochlear implant in. So he nearly lost his cochlear implant, the poor guy, because he's stone deaf without it. So, so because he was out of my normal range, and he had the cochlear implant, I was quite pleased I did that. But that's about the only time I've ever felt having a swab has been of any use. I think he grew a pneumococcus, strep pneumoniae, which was quite useful. Okay, I'll just keep going. So for milder cases, low Cortin or Kinniking, do you think it's the antibacterial bit of, I don't think the evidence around, there's no trials with low Cortin in it. I think it's just a best guess from BPAC. I don't think there's any trials with Kinniking either. Well, I'm not super au fait with that part of the literature.
Yeah, I think these I think the topical agents change the pH in the ear and get rid of those bugs that are overgrowing to help it go back to a normal environment.
What would you do if you start growing Pseudomonas in the ear and the pus is coming out?
So that's the most, that and Staph aureus are what you grow. But it doesn't necessarily mean that you need to direct your treatment towards them. So if you're, that's why we don't like swabbing up front.
Okay.
Because it will direct you towards ciprofloxacin eardrops when these ones should be just as good.
And it's interesting, when I look at American guidelines, they seem to be quite heavy on the ciprofloxacin drugs. We're much more cautious here, aren't we?
Yeah.
Appropriate so, okay. So that's necrotizing. If you think you've got necrotizing fasciitis, call the ENT registrar and tell them that's what you think it is. And there's no way they won't accept the patient. I'm just going to look at a few questions here. So unilateral marks suggesting maybe more likely bacterial. What do you think, Gary? Do we know?
Not in a kid. Oh, sorry, what are we talking about now? We're talking about ear discharge. Well, if we're talking about otitis externa and otitis media discharging, then generally they are bacterial. As you said, in kids, if you've got a perforated drum, it's most likely to be Haemophilus influenzae or strep pneumoniae that the cause. And then with otitis externa in adults, it's generally the cause is a change in the environment, and you will grow the bugs, Staph aureus and Pseudomonas.
Question here, can Bruce explain the concept that antibiotics only help with symptoms, not speeding up resolution of infection? Well, if you look at the randomized trials, the only advantage is that the pain symptom goes away about day 2, day 3. But if you look at things like glue ear as an outcome, there's no difference at 2 weeks, 4 weeks, 8 weeks, 12 weeks. So that's where that comes from. So it's not a pathophysiological explanation. It's data from clinical trials. Teach nose blowing and saline spray, don't know. Can we post-date a prescription? Would pharmacists notice? For like well, I think you can write a post-date on a prescription and tell the patient they can't cash it for 3 or 4 days if you want to give a delayed prescription. I don't know if some of the pharmacists would like to comment. How much notice do you take of the dates? Still about an aged residential care. I think that's the chronic perforations. And this person works in Glen Innes. Should you give oral antibiotics instead of drops if they have a perforation? I would say no. Gary says no. I see adults with usually 40 plus with chronic perforations and Almari patients in Tauranga. Okay, so it's still an issue. That's interesting. Any benefit prescribing antihistamines for recurrent acute otitis media, especially when associated with nasal congestion? My understanding of literature is no. I don't think antihistamines. Volsol has supply issues. Could you comment on availability? As far as I know, it's not available. I spoke to my local pharmacist. If no suction available, how safe are we to gamble there's no underlying perf? Well, I think often the perforations heal anyway. So it's unusual to see a persisting perforation, because there must have been a perforation there in the first place in a child for the pus to get into the ear canal. But usually they self-heal in most cases. It's the minority of cases that you, in my experience, and I saw lots in northern Canada where you had tons of it. That was the biggest reason for admitting a kid to hospital, was we fed them, we gave them iron, and because they were all iron deficient, and they were coming off the reservations with pretty poor diets and poor health. Pharmacists say they can mix to create Volso if we write it on the prescription. Great. So we've got Vivian there, who I know is a pharmacist. Vivian, Vizio is AudioSol now and not funded. Okay, so Vivian, that's Vosol as it was. I think, was it just a misspell? AudioSol now and not funded. Okay. What's best for Pseudomonas and ear canals, Gary?
To not test for it in the first place.
Test for it.
but if
just
you're,
treat it.
if it hasn't cleared up with your Canacam or your Leucortin,
Just talk louder, Gary.
If it hasn't cleared up after a couple of weeks of whatever you've given, ciprofloxacin in the ear.
Okay. Candida in the ear, how to manage? Is that a pathogen or a passenger?
It's probably a passenger. You were going back, you were talking about Aspergillus before, and I think that comes down to using things like Leucortin, potentially as your first line if you've got black dots in there. But ear toilet, I think, is important for that as well. And I've never given any.
But just say it again clearly, Gary. We're just having trouble hearing you. Last sentence.
So I think ear toilet and initial treatment with something like Leucortin is useful in that situation.
Leucortin.
Yeah.
That's for aspergillosis or Candida?
For aspergillosis, I've ignored the Candida question because I haven't really come across that as been a problem.
I guess your Kenacum with some nystatin might help there.
Yeah.
What treatment options for discharging tympanic perforation in children and adults? I think it's the same. Topical antibiotics with or without steroids. Necrotizing fasciitis can be caused by empagliflozin, the new Jardiance. Pretty rare though. Good news here from for second line with endorsement, ciprofloxacin eye drops. It sounds like we can endorse it. Okay, you have to endorse on the prescription. Okay, well, that's nice. No, thank you very much, Lillian and Kelly. That's brilliant. What's the safest eardrop if there's possibility of an eardrum perforation? This goes back to the old thing of, are we putting aminoglycosides into the middle ear? And I've looked for data on this and I can't find anything about harm, not being studied properly. But of course, people getting recurrent otitis media may have a hearing problem anyway downstream. So it's a bit hard to sort out. Do you have a view on that, Gary? Or
so my view is that if you're not treating for too long, it should be fine. Certainly the health pathways in the Auckland region, the ENT surgeons have considered this for all these perforations, and they have concluded that it should be fine as long as you don't give it for too long. And we're talking about a couple of weeks maximum, really. So
Stancy, I can't quite, you say New Zealand Formulary states Kenacum and especially Cipro C/I. I don't know if that's cortisone. In perforated TM, thoughts on using in children with pus from ears? I think either. Don't think it matters. Hearing protection ear canal seems associated with otitis externa. Seems in my population, aviation, military, to largely be fungal. One sometimes associated with reusable active noise cancelling. Any view on that, Gary?
No, I don't know about that.
Can we use all topical drops for perforated eardrum safely? I think Gary would say yes, but for short periods. I think cochlear implants with infection need IM antibiotic. I would talk to the NT people. I think they probably want to see somebody if they had an infection. It's a hell of a thing to lose a cochlear implant. I wouldn't give just an IM antibiotic. I'd probably Yeah, so for most infections, can we tell patients to stop antibiotics when they are feeling better to avoid unnecessary long courses increasing resistance? Over to you, Gary. I think Mark Thomas would say yes.
Yeah, I'm probably somewhere in the middle. I like your 5.
But to speak up a bit, Gary.
I'm probably somewhere in the middle there, because you might be feeling better that day and not so much the next. So give yourself a little while.
Okay.
Generally, a 3 or 5 day course should be sufficient for the things that we've talked about anyway.
I think a study should look at cotton bud use. I think it's nearly universal. I think you're right there, Sarah. Nothing nicer than scratching the ear with a cotton bud. Yep, so we've got these, they're endorsed for CSOM. Pharmacists, we notice the date straight away. So prescribers, you can't cheat. But you could write, presumably, not to be dispensed until 3 days' time. So pharmacists always check the date's legal requirement. Pharmacy, yep. Script will be filled on the date stated on the script. Forward dating is fine, but won't be done until then. Okay, cool, good. How long can we keep person with ear drops for? Do they have to throw them out after 1 month? Don't know. Maybe one of the pharmacists can tell us on that way. Theoretical risk of neurotoxicity of perforation. Do we need to be concerned using some topical agents? Alan, Gary suggested short periods, probably not a problem. As I say, I've looked and looked for data on auditory nerve toxicity, and I just haven't, it just isn't, there isn't enough stuff on it. Okay. Can eardrops be used at all if there's a perforation? Yeah, they can. With e-prescriptions, not sure if you can forward the date. No reason why you can't manually change the date though, if not email. Cipro eye drops funded. Yep, we got that. Thanks, Viv. 30 days advised for most eardrops, but due to hygiene. But Cipro HC is 14 days HC. That's Cipro with hydrocortisone. 14 days after opening. Failure to resolve with amoxil, we use Augmentin. How often do you get a failure of amoxil, Tina? I'd be interested. And how do you decide you've got failure? Yep, okay, so we've got a few more questions. Got a couple of long. Try and keep the questions short because going to be a bit hard there. Okay, we'll just keep chugging on. We're just about hit, actually we've hit due date. So this is a congenital cholesteatoma. I've only ever seen one, but that I think requires referral because they like to remove that because that's an unusual looking drum. And the only reason I referred my one because I've never seen it before and it just looked weird. So sometimes relying on your experience. That's a more typical cholesteatoma. Sometimes they look like growths coming out of the ear from a zombie movie. You know, they look pretty bad. Mastoiditis, obviously a complication. I've only seen one case. What's your experience with mastoiditis, Gary?
So, seen a few mastoiditis, but the other thing that we do come across is cellulitis of the external ear. And the back of the ear, which obviously warrants oral antibiotics, but that's a more significant disease than mastoiditis.
Just the thing about roxithromycin here, there is a dispersible tab for kids. I long ago stopped prescribing erythromycin because of the GI things. I think we've never got the right dose for erythromycin, but I find roxithromycin effective for certainly skin infections. And respiratory things if I use it occasionally. But there is the dispersible tablet. So we're not going to get on to pneumonia, but Gary, do you want to have any closing remarks for tonight?
Generally, I think the point that you stated at the beginning is very relevant, which is a lot of the infections that you've presented are ones that we're trying to make people feel better, and the infection will pass on its own. So symptomatic treatment, consider antibiotics in those at-risk groups, and be very careful about whether or not they need any investigations, because a lot of them don't.
Right. So fewer swabs to the lab. Okay. So just so thank you very much. It's a huge audience we've had tonight. I'm just wondering where the it's going to be in the chat box. So if you go to the chat box, you can see the handout there. So it's a 14-page with common infection handout that we produced from the department. We've been doing that for about 15 years with lab tests, and before that, diagnostic med lab had helped us with it. We might be knocking on your door someday, Gary, to have a little look at it to check that everything's okay. So thank you very much for your time tonight. So for the audience, if you want the PDF, just click on that. So thank you very much. And thank you, Gary.
Thanks, Bruce, and thanks, everyone.